Dan, I want to pull you into the discussion a little bit earlier than we had planned. And why don't you talk to us about some of your consideration about how you pick the right therapy? And I know you've actually made some comments about, is fitness actually important anymore?
Sure. Yeah, I mean, historically, in the environment in which I was trained, and really up until just a few years ago, I think for all of us, the most important initial consideration was, is the patient a candidate for intensive induction chemotherapy? And if they were, that's what you did. And if they weren't, you didn't do a whole lot, or you didn't do a whole lot that could help them. We have data to show that over half of AML patients didn't even get treatment. And some of us, were maybe a little bit negative about learning about that data, but when you see the reality on the ground of the poor options and the horrible outcomes, it's not that surprising that people were so nihilistic. In the modern era, which modern is the last 3 years really, in which we practice, I think things are completely different, and the assessment of fitness for intensive induction chemotherapy, may need to be updated in an era when we have other treatment options. And so what I mean is that a patient's ability to withstand or not die from intensive induction chemotherapy, I think in the modern era doesn't necessarily commit them to that treatment. And Mark was getting at this with his sort of need for an early look at P53. So, you can be fit for induction physically and maybe not die from that treatment, but the question as to whether your disease will respond to that treatment, I think, is a crucial question. And if there's a patient that, is unlikely to die, but also has disease very unlikely to respond to it, I don't think, I think the way I'd like to see things move is that's not a patient that we subject to that treatment. So I think what's happening, what I hope is happening, is that the definitions or the assessments of fitness for induction will start to melt away a bit. And what I hope will happen is instead we'll have a new standard, sort of a standard where you have to prove yourself likely to respond to induction chemotherapy, and that's your induction candidate. So people who have a curative option from intensive induction chemotherapy, I think that's a reasonable, very reasonable, core binding factor, or other patients with certain molecular signatures. But other people who historically may have been fit for intensive induction chemotherapy, I don't think that that's appropriate for them anymore in the era we're going to talk at length in this panel about with some of these other exciting therapies. So I think things are really changing.
So it's almost, we should not focus so much on intensive therapy, but on effective therapy. You can take an unfit patient and make them fit with effective therapy. You can take a fit patient and make them unfit with ineffective therapy.
That's exactly right.
And I was going to make a comment too. I actually agree very much with Dan, and I think the question that we kind of all in training grew up is, who is absolutely not fit to get induction, and we're going to use that as the exclusion and then give it to others. I think hopeful, and a lot of data has to come out and studies are being done and phase 3 data has to be reviewed, but the hope is now it will hopefully switch in the next few years and say, who really needs induction? Can we actually not give induction to all the people who can get something that's equally or better and then leave out? So it's an inclusion-exclusion kind of switch, is at least where in the US the push or the hope or the drive is moving.
Well, I agree with these comments, but it's actually made it even more complicated because no one actually agreed on what fitness meant in the first place, and now we're adding in appropriateness for intensive chemotherapy. So where do you draw the line? Sure, core binding factors, very curable. Adverse karyotypes, P53, not curable with intensive chemotherapy. But how about that large group of patients with intermediate risk disease that have various risk factors? And I think all of this makes the decision making even much more complex. But what we've learned is that we have the time to slow down, put the brakes on, and think about what's the best option and what is the goal of our therapy for the next patient we see with AML.